initial slide that's on your screen. All of you will be muted throughout the call. So if you have questions, please do utilize the chat function and address the entire audience. If we don't have time to address all questions, we will plan to address those during upcoming and future office hours. If we do have time, then we will address those at the end of the session. And as you can see, all of the learning session will be recorded and the slides will be available. And we will let you all know exactly how you can access those. So I am Kate Remick. I am one of the leads for the Pediatric Readiness Quality Collaborative. You also have Crystal Bartley and Diana Finja, and we're so excited to welcome you all this morning into the Pediatric Readiness Quality Collaborative. So before we get started, we do have to provide a brief acknowledgement, which is that we are supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. And so all the information, content, and conclusions that are listed here are those of the EIC and us in particular, and should not be construed as the position or official endorsement of HRSA or the U.S. government. So just to give all of you a very brief overview of the Federal EMS for Children program and where it sits. For those of you who are not aware, the Department of Health and Human Services houses the Health Resources and Services Administration. And within HRSA is the Maternal and Child Health Bureau. And the Federal EMS for Children program sits under the Maternal and Child Health Bureau. And it is the largest single source of funding for pediatric emergency care from the federal government in the United States. And they support a number of different programs, from grants to national centers. You'll see that there are a number of grants that the EMS for Children program funds, from state partnerships to targeted issues grants and the like. Some of these you may recognize, particularly the Pediatric Emergency Care Applied Research Network. But we are with the EMS for Children Innovation and Improvement Center. And so the EMS for Children program funds two national centers. One is the EIIC, and the other is the National EMS for Children Data Analysis Resource Center, which is housed out of the University of Utah. And so we work conjointly to try to support all of the grantees and pediatric emergency care across the entire continuum, from the pre-hospital to in-hospital to rehabilitation settings and back around. And that is the role of the Federal EMS for Children program, and hopefully this gives you just a brief snapshot of where we sit. So here are some pictures of myself, Crystal Bartley, and Diana Finja. So I have been working on the National Pediatric Readiness Project since its inception, really in about 2009, 2010, way before the national assessment. I am a pediatric emergency medicine physician. I'm also an EMS physician, and I am one of the executive leads for the EMS for Children Innovation and Improvement Center, which, as you know, is based out of Houston at Texas Children's. Crystal Bartley is a quality improvement specialist. She has led many quality improvement collaboratives and is the project manager for the Pediatric Readiness Quality Collaborative. And then Diana Finja has a long history in nursing and trauma care. She has been with the EMS for Children program for a couple decades now, brings a wealth of expertise, experience to the table, and she is one of the project specialists for the hospital-based state partnership, trauma and measurement domains of the EIIC. I also would like to introduce to you all our colleagues at NEDARC, the National EMS for Children Data Analysis Resource Center, who are really foundational in supporting this project. As I mentioned, the National EMSC Data Analysis Resource Center provides a lot of data analysis and support for all of the grantee programs, and also to all the work that we do at the EIIC. So first off, we have Michael Ely. He is the director of NEDARC. He's been with NEDARC for also a couple decades now. Lenora Olson and Hillary Hughes are the co-investigators for NEDARC. And then we have Patty Schmuel, who is a data program manager. and Eddie Zamora, who is a business data analyst. Not included here, just for lack of a picture, is John Brummett, who is a data programmer, who is also helping us through the National EMSC Data Analysis Resource Center. And we could not make this project possible without their help and support. So today what we will be covering is what you see here on this slide. So we're just going to start with a brief overview and background on how we got to the Pediatric Readiness Quality Collaborative. There will be more history online if you're curious about the Federal EMS for Children program and the work that's been done there, just to be able to orient yourself a little bit more. But really today our focus is just to cover an introduction to PRQC. We'll then go through some of the basics of why specifically PRQC, the design of the collaborative, the overall culture of the Quality Improvement Collaborative, and then we'll talk a little bit about the team. We'll finish up with a snapshot of the intervention bundles and talk a little bit about your roles and responsibilities as champions and trainers, and then lastly, just some housekeeping. So as many of you are aware, the National Pediatric Readiness Project is really a collaborative project. It's a collaborative national quality improvement effort that was started a little bit before 2013. And the impetus for this project is based on a national joint policy statement, which is Guidelines for Care of Children in the Emergency Department. This was a policy statement that was jointly authored by the American Academy of Pediatrics, the American College of Emergency Physicians, and the Emergency Nurses Association. The Federal EMS for Children program has partnered with those three organizations in order to further develop and further pediatric emergency care through the National Pediatric Readiness Project and through the guidelines that are listed in that joint policy statement. And really the goal of this collaborative effort is to ensure that all children have access to high quality emergency care, regardless of their geographic location. Many of you are aware, at least now, if you weren't before you applied for this collaborative, that in 2013, we jointly launched a national assessment of emergency departments across the country. And it was a national assessment for emergency departments to see their own capacity to care for children. And really it was for this entire collaborative, this collaborative effort to see the nation's capacity to care for children. And it's only through that initial assessment that we're able to identify gaps and therefore make improvements. During that assessment, we had over 4,000 hospitals, or acute care hospitals, I should say, emergency departments that participated in the assessment. And that represented some 83% of emergency departments across the United States. And these were the common gaps that were identified and what has since led us to the Pediatric Readiness Quality Collaborative. So first and foremost, we noted that while there was improvements from earlier assessments of pediatric readiness, that only about 50% of emergency departments had physician coordinators to oversee pediatric emergency care, and only about 60% had nurse coordinators to oversee pediatric emergency care at their institutions. Also notable was that less than 50% of emergency departments self-reported the presence of a QI plan that included children or pediatric specific measures. About 2/3 of sites reported that they had been weighing children in kilograms only, and we know that this is a really critical patient safety measure. Approximately 2/3 had interfacility transfer guidelines in place that included children. We know that this is a requirement for trauma centers, but oftentimes that doesn't translate to medical issues for pediatric patients. And finally, that less than 50% of reporting emergency departments said they had a disaster plan that included pediatric specific needs for children. We also noted during that 2013 assessment that about 69% of ED visits occur in those EDs that have relatively low volume, so EDs that see less than 15 children per day. But most importantly, that some 80% of children, more than 80% of children, are seen in non-children's emergency departments. So this is where the majority of children are being seen. And this is where we really need to focus our efforts if we're going to ensure that every child, regardless of their geographic location, has access to high-quality emergency care. It was also noted that the presence of a pediatric emergency care coordinator was strongly correlated with improved readiness, and that the presence of a quality improvement plan is also associated with overall readiness. And this is really critical because if you're not measuring or evaluating the quality of care being delivered to a particular population, you have no idea of the actual value of it. And this is where quality improvement comes into play. So the top 3 barriers that were reported by those 4,000 plus participants in the 2013 assessment were that cost of training was too high, that there was a lack of educational resources, and a lack of a quality improvement plan for children, meaning that they didn't know how to start and they didn't know what metrics to use, and therefore, because it wasn't in place, they weren't able to make improvements in their overall readiness. And so the Pediatric Readiness Quality Collaborative set out to address these 3 barriers by trying to recruit all of you here to facilitate the training of personnel, which is all of you who are on site at these local facilities, to provide educational resources, and to provide quality improvement education with pediatric specific measures that address the gaps that we just highlighted. So our aim for this overall collaborative is that by December of 2019, we hope that the median pediatric readiness score for all participating sites will collectively improve by 10 points. And those of you who are very familiar with the National Pediatric Readiness Project recall that the median pediatric readiness score overall for all those 4,000 participating sites was 70. So there is definitely room for improvement based on a 100-point scale. This is the overall structure of the collaborative. So we mentioned the EMS for Children Innovation Improvement Center, now on to be called EIIC. We mentioned the Health Resources and Services Administration, NEDARC, the National EMS for Children Data Analysis Resource Center. We have 10 wonderful subject matter experts from around the country that are helping to support this collaborative. And then also an advisory committee that is composed of representatives from all of our national stakeholder organizations, and we'll talk about them shortly. Under that overseeing body, we have the PRQC administrative team, which is myself, Diana Finja, and Crystal Bartley, and then the NEDARC data technical support team, who I introduced earlier. Then comes all of you. We have 16 total teams within the Pediatric Readiness Quality Collaborative. And then in addition, we have 4 intervention-specific work groups: weight and kilos, abnormal vital signs, interfacility transfers, and disaster planning. And we don't expect that each site would be on all of these work groups. It's up to each site individually in terms of what interventions they will like to work on. But we're all working together to try to improve pediatric readiness within the participating sites. So these are the members of our advisory committee. We have, as you saw earlier, with the grant programs that are funded through the Federal EMS for Children program, are state partnership grants. And so the EMS for Children program provides funding to every state and U.S. territory to help improve pediatric emergency care. So we have a representative from the EMS for Children State Partnership Managers Group. We have representatives from the American Academy of Pediatrics, American College of Emergency Physicians, and the Emergency Nurses Association. We also have representation from the American Academy of Family Physicians, the Federal Office of Rural Health, the Pediatric Trauma Society, the American College of Surgeons, and then from 2 groups that are out of Canada, one group called TREC, which is Translating Emergency Knowledge for Kids, and lastly, the Ontario Provincial Council of Maternal and Child Health, who are also extremely interested in pediatric readiness and improving pediatric readiness across Canada. And so the work that you all are doing here, the work that we're doing together will help to inform them so that they can follow in suit with improving readiness. But I want you all to take a close look at all of these organizations because you will see that all of these organizations are very much invested in pediatric readiness for children in the emergency department. And they are all here to help support you through the work that they can do within their national membership. So before we get started, when we talk about quality improvement collaboratives, it's really important that we set the groundwork by understanding the culture of a collaborative. The culture of it is that we're all here to improve. There is no shaming, but we're all here to help build each other up and encourage success. And in order to do that, we share a couple specific philosophies. One is that we're all here to teach, and we are all here to learn. There's no one particular teacher. Yes, there are trainers that'll help to guide us and support us, and we here at the admin team are here to help support all of you. But more importantly, we're all here to support each other. We learn from you just as you learn from us. We will try to teach you just as you will also help to teach us. And in order to make that possible, we all have to be very transparent with one another and with our trainers and with the entire collaborative as a whole as to what our real challenges are. Because unless we can be forthcoming with our challenges, we won't get the help that we need to really address them and to make progress. You will notice as we move through the collaborative that many other sites, many other champions and/or trainers are facing the same challenges, the same barriers, the same difficulties. And it's by way of working together that we're able to overcome those, and that will result in success. And more importantly, what I wanted to say is that this really is intended to be a grassroots effort. This is about every day for you all. This is about being on the front lines, and this is about children and helping to be the pillars of your communities when it comes to pediatric emergency care. And so just try to remember that while there may be challenging moments, that we're all here to make sure that children have access to high quality emergency care. So I'm now going to turn this over to Diana Finja, who's going to talk a little bit about the collaborative team structure.
Hello, everyone. And as Kate said, we are very excited to have you all as part of our team, our extended team, out into the communities, into the hospitals where children are often treated, so that we can all work together to improve the abilities of one another in providing care for our kids. So let's talk about the collaborative teams and what they're all about. Each team consists of a training site. The training site is typically, and has been as we've met our trainers thus far, a comprehensive medical center are a children's hospital that treats a high annual volume of pediatric patients. Typically, they're seeing more than 10,000 children a year. And they have an established clinical quality improvement process in place. They have patient safety programs in place and a risk management program in place. For most of you who are on the call today, you are our affiliate site, and we just can't do this without you. So if you don't think you're important, you're extremely important to this entire project. The affiliate sites are any ED or acute care hospital. You can be freestanding or a satellite ED, and you agree to work closely with the training site to help implement a pediatric quality improvement program in your own emergency department with your own emergency staff and leadership. My slides aren't advancing. Crystal, can you move them? I'm not sure why. There we go. For those of you who are wondering where the teams are and what the sites are, we have 146 participating hospitals at this point in time, and it looks like every one of you have sent representation, and maybe several of you are in an office together listening to us today. We have 19 training sites and 127 affiliate sites. So again, we're very excited to have the interest and the motivation to help improve care for kids. And as you can see on this map, we're pretty geographically diverse, and we're very excited that we see different segments and regions of the country well represented. Next slide. This slide is showing you the teams, and as you can see, each of our teams have their own little names that they've come up with, and we're delighted that we have such good names such as 8 is Enough, Fight Response Team, RET for Kids, Pediatric Pit Crew, the Remock Minions, which relates to one of their hospital characters that supports them, Whisper from Wisconsin. We have a couple of teams from Oregon and a couple of teams from Georgia. We have a team from Tennessee, and as you can see, we're pretty diverse with those teams. One of the pieces that may be a little bit confusing, some of these teams actually have 2 training sites that are working together to meet the needs of the hospitals in their area. Next slide, please. Is that it's not coming up on my screen. There you go. Collaborative members, as we mentioned, we have a trainer. The trainers that you will be working with will be either a physician and/or a nurse at an individual training site. Most of the trainers have reached out and have several team members who are helping with the training that they will be doing with the affiliates. These individuals frequently serve as PECs at their individual hospital or the Pediatric Emergency Care Coordinator. They will be disseminating educational content to each of the affiliate sites, and they will be helping you, the pediatric champions, to develop and implement a pediatric quality improvement program. You, our champions, may be a physician or you may be a nurse at an affiliate site. You've been identified by the particular hospital as by the site's hospital administrator and ED leadership as being the champion for kids in your facility. And you have agreed to implement a pediatric quality improvement program and participate in the hospital-based associated activities. Next slide, please. Okay. The role of the trainers is to meet regularly with the PRQC administrative team. They have been meeting with us since January, actually, going under some basics, learning the basics of the collaborative. They'll continue to meet with us to review team progress and to participate in collaborative updates. Our trainers will also be participating with you in learning sessions as those take place during the course of the PRQC. They will be coordinating and leading regular team meetings with the sites. So all of the affiliates that are part of each of the teams will be meeting on at least a quarterly basis, but maybe more frequently here and there to get things started. The trainers will be conducting 2 to 3 site visits with each of the affiliates. This is to get to know you, to get to know your emergency department, and get to know some of the challenges and obstacles that are creating problems for you all, while at the same standpoint identifying opportunities to help you strengthen your emergency department care through pediatric readiness. They will also be disseminating resources that have been identified by the EIIC and even one another so that we can share the resources, and they will support you, the champions, as they implement local QI plans. Next slide, please. The role of the champions is to attend all PRQC events that's hosted by the collaborative and the training sites. This would include the learning sessions, such as the intervention webinars that we're going to be embarking on in a couple of weeks. Office hours, should you have questions that you need help with or you don't understand in regards to the collaborative itself. You will be attending regularly scheduled team meetings with your other affiliate sites. Remember, if you do not attend these team meetings, you will not have the benefit of being part of a collaborative and learning from one another, as Kate talked about just a few moments ago. We also need your help in facilitating the in-person or the virtual site visits with the team trainers. because the team trainers aren't going to be the ones who can coordinate this in your own emergency department. So you'll have to work with them. And from the original data that we've been getting in from the various trainers at this point, many of you have completed your site visits. Many of them have been in person, and some of them have been done virtually. So we're excited that so many of the site visits have already taken place. We know a few teams joined late, and their site visits are still on the docket, but they have been planned. Your job as a pediatric champion is also to lead the local quality improvement activities. You are the leader in your facility. Your administrators have identified you as the champion to lead these activities, and therefore some of the things that you will be doing or should already have considered doing: pediatric readiness assessment. I think we're pretty much everyone has completed that at this point in time, or we just have a few out. Crystal will know closer on that. Chart reviews, as we get into the bundles, you'll be the one doing the chart reviews and collecting some small pieces of data associated with the various intervention bundles so that we can track progress. You'll prepare educational content for your care team. Your trainer will be handing off materials to you, and as you work on your intervention bundle, you will be identifying some of the needs for education, and we've already identified numerous resources to help you as you work with your care team locally. And generally, you are the spirit, you're going to lead the improvement strategies that are focused on at your individual institutions. Next slide. If we look at the collaborative design, there are 4 phases of Pediatric Readiness Pediatric Readiness Quality Collaborative. The first of these is orientation. Our trainers have gone through this already. You are going through it. Many of our trainers have joined again to hear and learn what you are learning today, and this goes through June the 15th. The mobilization phase will be the next phase, and that will begin on June the 19th as we begin to roll out the intervention bundles. And you will have extensive education on the bundles themselves, and some of this education will include some pearls of wisdom from our subject matter experts. You will begin convening local QI teams. You'll be identifying who are the right players to help you implement change, and you'll be beginning to develop plans for implementation, data collection, and submission. The third phase, implementation, will begin this September, and Crystal's going to really talk a lot about that, because this is the phase that is just critical that we all get started at the same time. By this time, you should have looked over your PEDS Ready data, identified where the significant gaps are. Look at the gaps in comparison to the intervention bundles. You should have decided which intervention bundle you're going to work at, and you're going to begin to look at some of the measures that need to be for tracking purposes, and you'll be providing feedback to your care team regarding your progress, and that will continue through December of 2019. So this isn't a rush process. If in fact you get through to the 4th phase, which is sustainability and spread, and you get there early, you could in fact embark on another intervention bundle. And if you have a large enough team, you may want to even consider moving forward to talk about doing 2 intervention bundles at the same time. But we're encouraging you to identify that focus bundle to start off with. Sustainability and spread means you lock your progress so that your hospital's already made, and you continue to build upon it. And you're actively disseminating your best practices and knowledges about the interventions to not only your own team, but also internal team at the hospital, but also to your team that you're part of in the collaborative. And those best practices will be brought to the surface for the PRQC collaborative in general so that we can share those nationwide, and that will take place from September to December in 2019. And I think at this point in time, we're about ready to move this onward to Crystal to talk about launching.
Hello, everyone, and welcome to the PRQC. It has been great to watch the sites go from the phase where they're submitting applications to their official kickoff. And so here we're going to start with this first slide. And it's really one date that I want you to keep in your mind for this summer, and it's that we will all launch our improvement efforts on September 1st. So that's our goal as a collaborative. That should be your goal as a team. That should be your goal as a training site and as an affiliate site. So remember, September 1st is our target. Here you have a snapshot of our key driver diagram, and so we're going to go ahead and just jump in with some of that QI education. A key driver diagram is really a visual display of a team's theory of what drives or contributes to achievement of a project aim. And so Kate mentioned earlier that the PRQC has the aim statement that by December 2019, we want to improve the median pediatric readiness score collectively by 10 points. And so to get there, we're going to use some sort of targeted key drivers, and that means that we're going to focus on pediatric patient safety. We will focus on pediatric assessments and reassessments. There will be a focus on timely, effective, patient-centered care, and then finally we will have a focus on disaster planning. And this ultimately leads us to our intervention bundles. As Diana mentioned earlier, we are going to focus on 4 areas of improvement. One of those being that we will record our pediatric patients' weight in kilograms, that we will develop a notification process for abnormal vital signs, that we will integrate interfacility transfer guidelines at our hospitals, and then we'll also establish disaster plans that include children. These are the 4 intervention bundles, and here you'll see the bundle release date and then the deep dive. So what you can sort of consider the release date is the time when we will send all the sites or make available online the intervention bundles and all that comes with it. And so those will typically be released or always released the Friday before the deep dive. And so the disaster planning bundle will have its deep dive on Tuesday, June 19th. The abnormal vital signs will have their deep dive on Tuesday, June 26th. Interfacility transfers will have their session on July 10th. And then weight in kilos will be on Tuesday, July 17th. So if you haven't realized already, Tuesday is literally the go-to day for PRQC events. And so whenever we're hosting an event, it will almost always be on a Tuesday. And all of the content that will be released will be on our website, and we'll send you online information and newsletters just to keep you updated. Now here's the thing. You don't have to attend all 4 sessions. You may decide to attend only the session that your hospital has decided to select for their intervention strategy. We will, however, record all of these sessions for future viewing. So let's say your care team is unable to attend the deep dive. You'll have that recording available for future viewing before you launch on September 1. The deep dive webinar will include an in-depth description of the intervention bundle. You will have your subject matter experts on that call. There will be someone providing data support, and then there will be a member of the PRQC admin team. So the bundle content, our plan is to give you everything that you need to really drive these QI efforts from the ground up. So that begins with this concept called an environmental scanner survey. And what we really want you to do is take your PEDS readiness assessment that you should have already completed, understand what gaps exist, if there are any barriers or challenges within your emergency department, and then possibly use that to drive your areas of improvement or which change strategies or improvement efforts you select for the next couple months. We will have an in-depth overview of the bundle itself, give you some background information, really describe the scope of that bundle. You'll have a list of change strategies that we're proposing. There will also be a list of the quality measures. So we're not just rolling out interventions, but we are really going to measure our processes and our outcomes related to care. You'll have a data dictionary available, which will have very detailed information regarding the variables that we'll collect, the parameters for data collection and data entry, and that will be something that we're partnering with our NEDARC colleagues. There will be toolkits available, so we'll have resources, suggested readings, pathways, you name it, we'll have it available. And some of these materials have been established over the years by some of our national partners, and so we didn't reinvent the wheel. We're definitely going to make the most of some of these best practices that have been established. And then lastly, an implementation guide. So here's the thing. We realize that several of our champions, this may be your first time really doing quality improvement work. You may have been a participant or on the sidelines, but we really see you guys as the champions that will be driving this care. And so we're going to give you an implementation guide that walks through how do you assemble your ED-QI care team. These are the individuals that should be in the room with you. This is what the agenda should look like. It will include everything from reporting, what to expect, some considerations, even talking points that you can use with your C-suite within your community of hospitals or your network. And so we're trying our best to make sure that you have everything that you need to really reach that aim. So now what I'd like to do is walk you through very quickly some high-level points about each intervention bundle. So we'll start with Bundle 1, which is the weighing of children in metric units. We have had a great summer, and really I'll say for the last year, great support from our subject matter experts. And so for weight in kilos, we have Sue Cadwell from Hospital Corporation of America, the Clinical Services Group, and Dr. Marianne Gaucher-Hill, who's the Medical Director of the Los Angeles County EMS Agency. Our aim statement for this bundle is that by December 2019, 100% of our pediatric patients will have their weight measured and recorded in kilograms. The pediatric patient population will be defined a priori by participating sites. We as a collaborative will not establish an operational definition for what constitutes a pediatric patient. That will be site specific. And so here are the key drivers. And remember, I told you guys earlier, these are sort of the strategies that we'll take to achieve our aims. And so some of the change strategies will focus on developing a policy statement. There will be some need for infrastructure change. So it could be processes that are currently happening at your ED that we may want you to consider some upgrades or improvements. We asked the question when you first started the collaborative or submitted your application, what type of electronic medical record do you have? And that really helped drive our decision to say, well, what sort of optimizations, changes, upgrades can you make to your EMR platform? And so we have suggestions related to that. One of the major pieces to quality improvement is education. So we are going to provide you with objectives that you should consider. We even have some PowerPoints and slide decks to assist you with educating your care team on best practices. So that will be a separate set of change strategies. You can't just teach, you must reinforce. So we will have some change strategies or improvement strategies or ideas for how you can reinforce these adult learners. Then we're going to have sections for deep dive. So we realize that some sites don't have a problem with weighing their patients, but we're going to give you more work to do. So it doesn't just stop with weighing the patients. We're going to look at things like your prescribing patterns, medication administration. This really gets to the safety piece of why we measure our patients in metric units. And then lastly, patient and family engagement. We want to ensure that we have a way of really bringing the family into the ED process. Bundle 2 is the recognition of abnormal vital signs in children and a notification plan for the care team. The subject matter experts are Deanna Gillespie. She is the coordinator of the Texas Pediatric Quality Collaborative at Dell Children's Medical Center in Austin. And we have Dr. Madeline Joseph, who is a professor of emergency medicine and is also the Florida president for the Florida chapter of the American Academy of Pediatrics. And the aim statement for this bundle is that by December 2019, 100% of our pediatric patients with abnormal vital signs will be identified by the healthcare providers in the emergency department. And so the key drivers for this will always be starting with the very basics. What's the policy? We'll have notification protocols in place, and this is really about sort of giving you strategies that you can use to engage the care team when a patient flags or you identify abnormal vital signs. As I mentioned with one of the other bundles, we will have EMR Optimization Education and then knowledge reinforcement for the care team. Next, Bundle 3 is the interfacility transfers for pediatric patients. Our subject matter experts are Lisa Nichols, who is a trauma program manager at Dell Children's Medical Center of Central Texas. We have Sally Snow, who is an independent pediatric emergency department / trauma nurse consultant, and Dr. Tony Woodward, who is the medical director of emergency services at Seattle Children's, and he was also the past chair of the American Academy of Pediatrics Transport Section. And here we have the aim statement for this bundle, and it's that by December 2019, 100 of our participating sites will have interfacility transfer guidelines that include all 8 of the pediatric-specific core components. And those core components include the process for initiating a transfer, some statement about referring and receiving center roles and responsibilities, a process for selecting appropriate receiving centers, a process for selecting appropriately staffed transport services, a process for patient transfer that includes informed consent, a plan for the transfer of the patient's medical record and their personal belongings, and then lastly, a plan for provision of the directions and referral institution for patients and families. So you'll notice we always get back to that patient-family engagement, and that can be done in the form of a transfer informational packet. The key drivers for Bundle 3 is that we will help institute policies and procedures for your site. There will be an education piece. The sort of integral piece to this guideline or this bundle will be communication and follow-up. There will be a patient and family engagement portion. And then lastly, you'll notice that technology will also be an area of focus. Then lastly, we have the disaster planning for a pediatric population, bundle number 4. And we have a series of subject matter experts. We begin with Dr. Steve Krug, who is a professor of pediatrics. He is the chairperson of the American Academy of Pediatrics Disaster Preparedness Advisory. We have Oscar Enriquez, who is the project coordinator of ED services at Dell Children's Medical Center of Central Texas. We have Patricia Frost, who's the Director of Emergency Medical Service for Contra Costa Health Services. We have Dr. Brent Kasney, who is an assistant professor at Texas Children's Hospital and Baylor College of Medicine. He also serves as the director of the Disaster Preparedness Domain here at the Emergency Medical Services Innovation Improvement Center in Houston. We have Dr. Ariel Fusco, who is a fellow that's currently working on disaster planning, and she's at Dell Children's in Austin. We have Laura Aird from the American Academy of Pediatrics and Brianna Smith from the American Academy of Pediatrics. So this bundle definitely has a lot of support from our partners. And the aim statement is that by December 2019, 100% of our participating sites will have a comprehensive disaster plan that includes all 7 of the pediatric-specific domains. Now, these domains range from pediatric disaster coordination, coalition building, pediatric surge capacity, essential pediatric resources, disaster triage, decontamination, tracking, and reunification. This bundle is the largest of the 4, and we are giving hospitals the option to do a phased approach with this bundle. So we will roll out interventions related to domains 1 through 4 this year, and then bundles 5 through 7 will be rolled out in 2019. Some sites may decide to only really focus on 2 to 3 of these domains for the entirety of the collaborative. There will be some flexibility for this particular bundle, but we'll go definitely have a true deep dive into this bundle on June 19th. This is our first deep dive. The key drivers you'll see here, so for Domain 1, the Pediatric Disaster Coordinator, you will focus on things like the policy statement, key personnel, and education. coalition building, it's simple. It's all about team building. For Domain 3, it's about pediatric surge capacity. So you're going to look at things related to the infrastructure, education, and then we'll also be providing opportunities for simulation. And then Domain 4, it's infrastructure, all infrastructure. What are those essential pediatric resources that are needed? So we're going to switch gears a little bit and talk about the incentive program. So we realize that you are spending a substantial amount of time for the next year and a half working on this QI initiative. And so we want to provide as many resources as possible as an incentive for you as a trainer, you as a champion, and even your care team. So we will provide continuing nursing education for all of our nurses, continuing education credit for our physicians, and we will start awarding those credits for the intervention deep dives and all of our future learning sessions. And so we'll send out correspondences related to that process in the coming weeks right before we have those sessions. The other opportunity is for maintenance of certification for all of our physicians. It's with the American Board of Medical Specialties, and that will officially launch on September 1st, 2018 when you start rolling out your interventions. So that's definitely a carrot to get your physicians involved on the front line to really garner support. HRSA will be providing a letter of support that can be posted in your local ED, really showing that you've made a commitment to do this pediatric emergency effort, and so that's a great initiative. We will be providing QI educational offerings throughout the collaborative, but definitely this summer we'll have some QI education for those hospitals that need it. And then over the course of the collaborative, we'll have some PEM focus or pediatric emergency medicine focus educational content that will be shared online or during our learning sessions. And so now I'm going to pass the mic back to Kate, and she's going to talk to you about time commitment.
Great, thanks, Crystal. So we really just wanted to reiterate that with all of these bundles and with all the work of this collaborative, it's really site-specific. So you move forward with whatever speed you feel like you can, and to accomplish that which you set out to achieve. So we tried to make all of these bundles and all of this work flexible, such that if a site is really, just struggling with some initial structural measures like developing a plan, that can be the focus for the course of the collaborative. But for those sites that have a lot of engagement and buy-in, they may be able to move forward more quickly. And so you'll see that with all of those bundles that Crystal just introduced, that they start with some structural components, just the infrastructure of the emergency department, that they will move through or take you through, guide you through process-specific metrics, and eventually to clinical outcome-specific metrics that truly and directly impact the care being provided to children. But we don't want to overwhelm you by all of that, and just keep in mind that this is to move forward with whatever speed works for you as an individual site. So in terms of achieving your goals, we know that on the local level, you really need to have buy-in from your site. And this is why with the application, we requested letters of commitment from ED leadership and also from hospital administration, because we know that a single individual, while you can be the champion to move this forward, you need to make sure that you have support to be able to do so and to actually make changes at the local level. So we know that it's going to require regular time to check in with your local ED leadership, through any of your team. It may be more than one champion at a given site, and to really review the bundles and to decide which bundle makes the most sense, initially at least for your site. You may choose more than one as you move through the collaborative, to make those selections and to identify those strategies that are likely to be most effective, and that you have the support to be able to do so. Before we launch on September 1st, you have to know your starting point. You have to have a baseline. And that's where the NPRP assessment comes in, and that's why we ask everyone to please repeat that as the starting point. So you should have done that by April 15th. If you have not, please, please, please get that in, because that's really critical for knowing where your gaps are. We'll notice with the NPRP assessment, which is an open portal, that sites may complete the assessment and months later they may do it again and identify different gaps or even potentially new gaps as things change. So it's really important that you as the champion have completed that assessment so you as an individual know where those gaps are. With each of the bundles, we will also have some additional questions that you can ask of your site or identify within your site to try to see if there's particular gaps that you also might want to address, and really to become familiar with the current processes around whichever bundle or bundles you choose to work on. So if it's weight in kilos, then really understanding the current processes in your emergency department of how children go through the triage process, how they are weighed, who does it, if there's variability, and really just trying to familiarize yourself with those processes so that you can choose the best change strategies as you move forward. There will be some regular meetings that you'll want to set up with your local implementation team. So by local implementation team, I'm talking about all those people at your local site, so hospital administrators, ED leadership, and your local ED team. And really just talking to them about, this is the project, this is the collaborative, this is you know, the bundle that we've chosen to focus on, and these are the change strategies that we've identified here. And really educating your team and letting them know about the data collection. And as you'll see as we move through this collaborative, you'll understand that measurement is critical to quality improvement. If you can't measure improvement or measure the change, then there's no way to know if the change you implemented is truly resulting in improvement. And so we will be talking a lot about data because analytics are core to quality improvement efforts. As you move into that implementation phase where you're really starting to collect data, look at your processes, looking at the changes that you've done, you'll probably want to meet with your local team, again, to let them know how things are going or where you're having troubles so that they can help support you, because that buy-in piece is going to be, is going to take you through this collaborative and is going to lead to your success. And then as we get more towards the end of the collaborative, you'll probably want to set up another meeting with your local team to let them know about how things are going and how the changes that you've chosen to implement may be sustainable. And think about the communication that you might have to hospital administration about what has been done and how it has resulted in improvements, either in readiness or actual care as measured by the work that you do. So that just kind of gives you an overview of some of the work that you're going to be doing at the local level. Again, these are not necessarily meetings every month. This is all going to be dependent on your time, availability, on the buy-in that you have at your site. These are suggested ways to be successful in this collaborative. So we'll go to the next slide. These are all the meetings that we have set up to help support you. What you'll know is that each of the trainers for your teams have set up regular phone calls with either Crystal, Diana, or myself as part of the PRQC admin team. And these are really just check-in calls just to make sure that things are going well from the trainer's perspective and to provide any additional support that they might need. We are also holding monthly office hours. These are available to anyone. Nobody is required to attend any of these, but we're trying to make ourselves as available as possible to you in case questions come up or you're really struggling with a particular issue. We still encourage you to use your trainers as they have a lot of experience in implementing quality improvement at their sites. They have a lot of experience in pediatric emergency care, and they're here to support you. But during these office hours, we're also happy to provide additional input. It may be that if you choose to join these office hours that you let your trainer know so that they too can join and listen to the responses and hear the questions that you have and maybe questions that other teams have. These are intended to be unstructured, really. If there are issues that pop up or questions that pop up, we'll answer them there. And for those of you on today's call, if there are questions that pop up in the chat box that we're not able to get to, we will be addressing those during the office hours. We then also will have regular learning sessions, and these are intended for everyone. So these will occur approximately every 6 weeks. Some are a little more spaced out depending on holidays and that sort of thing, so that we make sure we can get as many people as possible. But during these learning sessions, we'll be providing some formal presentations. We'll also be providing some updates on the performance and progress that's being made within the collaborative. We'll be highlighting some best practices, some innovations, some strategies, some tools, and this will be a really great opportunity to all come together. And it really speaks to the transparency of a collaborative, which is we're all teaching, we're all learning from each other, and that's where we're going to be doing a lot of that. We will also be hosting intervention work group calls. So these are focused on each of the 4 interventions. So these will be occurring essentially quarterly. And again, it'll be intervention specific. So we'll have one work group call focused just on weight and kilos, talking through some targeted discussions, some change strategies, some key drivers and barriers that folks are facing. Again, highlighting some specific tools or techniques or best practices. But we'll have separate ones for each of those 4 interventions every quarter. So keep an eye out for when those are occurring so that you can try to join if you're working on a particular bundle. But we expect that any site that's working on that bundle will make their best effort to be on those calls. There are then team meetings, and these are specifically with your individual teams. So if you recall, there's 16 teams that are all part of this collaborative. And so this is really for each of the trainers to meet with their full group of affiliates and really work together. And this is really where that transparency becomes most critical, because this is when you all can really dive into the weeds, dive into some specifics, talk about your progress, talk about the buy-in, talk about the barriers, talk about progress made, and really be able to learn from each other in a way that we won't be able to do necessarily during those learning sessions, because we just won't have as much time. And so we really want you all to put a lot of value and emphasis on these team meetings, because this is where you really can begin to grow and move forward. And then lastly, you all should be aware, or should have already had or scheduled your first site visit. But these site visits are a real opportunity for you all to get to know each other on a one-on-one basis. So for each affiliate site and the champions to get to know the trainers. We'd love for these to occur in person, but note that that's not always possible. So virtual is absolutely fine. There's a lot of great technology to help support this through the use of iPads and the like. But it really gives the trainers an idea of where each of the affiliate sites are at in terms of the current baseline of emergency care, and help to identify some potential change strategies that will be most effective. It also helps to garner the support of that local QI team and local ED hospital administration team. When that trainer comes in and is able to meet with everyone and really explain the process of this collaborative, it provides some clarity, the opportunity to answer questions, and to all be on the same page. There may or may not be a second site visit at some point during the middle of the collaborative just to check in. And then at the very end, we are asking for a final just to reassess and make sure everyone's ready to move forward in terms of sustainability and final reassessments. So Crystal walks through all of the 4 bundles, and we have specific training on each of those bundles to get you guys started. So if you have a sense of which bundle you think you're going to be working on, please mark these dates on your calendar, make note of them, because this is when we will be doing deep dives into each one in particular. We will be sending out the bundles to all of you 4 days before the webinar, and that's just so that we can focus on one at a time, so that you can review it in depth before we get started and be prepared to ask questions and make sure that you understand the activities, change strategies, potential key drivers associated with each of those bundles. So the first one will be focused on disaster. That'll be in mid-June. The second one will be focused on abnormal vital signs. That'll be the end of June. We're going to skip the 4th of July week, and then we'll come back on July 10th with interfacility transfers, and then on July 17th with weight and kilos. All of these sessions will be recorded, so if you happen to be on vacation and just absolutely cannot make it, you're out of the country or whatever it might be, we will be recording these, but if you plan to be on one of these bundles, please make every effort to attend because it will be much more beneficial in person. You'll be able to ask those questions if you're able to be on that call. We'll then be continuing on with global learning sessions, and we will have one last global learning session before our September 1 launch. So just keep that in mind. So on August 28th, we'll just get everybody back on the same page, answer any final questions, and make sure folks are ready to move forward with their first change strategies. We'll be checking in twice in the fall, in early October and early November. We've given everyone a little bit of a break over the holidays, and then we'll come back in mid-January with our final 7 learning sessions. That'll really be a lot of implementation, change strategies, a lot of work will be done in 2019, and we hope to hit the ground running come January 15th. Oh, just of note, and I'm sorry I didn't say this before, all of those learning sessions will be at the same time. You'll see those down below depending on what time zone you're in. So if you're in Alaska, Pacific, Central, or Eastern, it's always 11 a.m. Central Time when those learning sessions will occur. And those are all Tuesdays. In terms of office hours, again, we will be hosting those. These are open. The first one will be on June 12th, so next week. That's in case anybody has some last questions from today's call or what to do or any concerns or issues. We'll be happy to address those there. Then we'll be having some additional office hours on July 24th and August 7th before the launch. We're not planning on recording these sessions, but you're welcome to join and just ask. We are also not going to be emailing these calendar invites in advance. So if you want to join, please make sure you mark these on your calendar and just call in. We will make sure that those call-in details will be on our regular newsletters or emails, recap emails out to the group. So you'll have those on there. You'll see a section for upcoming dates and calls. So just be on the lookout for that. And then we'll have a couple more scheduled in the fall after folks have implemented. So in terms of, team meetings, these are just for the local teams again. So this is the trainers working with all of the pediatric champions at the affiliate sites. And these are going to be planned by your trainer, by the training site. And the timing will be, based on however it's determined by those trainers and your all schedules. These are not going to be hosted by the EIC. The PRQ admin team will not be part of these team meetings. These are really for you all. They may be in person, they may be virtual, maybe teleconference, depending on how the trainer wants to run those. What we will say is that because there's a steep sort of learning curve and kickoff of September 1st, we've encouraged the trainers to go ahead and schedule several of these team meetings. The first one sometime in June, if possible, after this first learning session, and or sometime in July during this intervention webinars, just so any questions can be answered. We can identify which bundle everyone wants to work on, come up with a plan, talk about local buy-in and hospital engagement in the process, and begin to think about individual site-specific smart aims. Again, to check in August prior to launching with the implementation phase on September 1st, so just to make sure everybody's ready to go and has a plan in place. And then another meeting in September, October, just to check in. After that, these meetings may be more spaced out. It depends on the needs of the group and of the team. But at minimum, these should occur on a quarterly basis, just to make sure that everyone is on the same page and that nobody gets lost in the work or the shuffle. So at this point, I'm going to go ahead and turn the slides back to Crystal to go through a little bit of housekeeping.
Okay, folks, so just as a quick disclaimer, all of today's slides as well as a recording will be available. It'll be available this week, and so when we send you an email that's really like a newsletter or a recap of today's learning session, you'll have a link to access the slides as well as a recording, and so that's something that you can share with your colleagues or save on your local drive for future viewing. So we'll definitely send you all of this information. We know it's a lot to sort of digest at one time, but we'll have it available for future viewing. Now let's really discuss some of the housekeeping issues. And all of our learning sessions will have some element of this. It's really just to ensure that the teams are staying on target, and we'll start this discussion with data use agreements. And so Kate mentioned earlier that we want to ensure that we have some transparency in the collaborative. I mentioned that we will have quality measures associated with each of our intervention bundles, and so the very foundation of this is that we need to establish data use agreements. And so to expedite this process of establishing that DUA with all of the affiliate hospitals and those training sites that wish to submit data, we're requesting the contact information for the individual who has the power or authority to sign the agreement. Now, this individual may be your hospital CEO, research administration and compliance officer, or someone from your contracts and licensing group. We send an email to all of the primary pediatric champions or their co-champions requesting this contact information, and I've only received it for about 30 sites. As we mentioned earlier today, there are 140 or so of you all. So that means we still need contact information for your designee. I'll send out a reminder today to all of you following today's call, and this will be separate from your recap. It's strictly related to the contact information that we need to execute these data use agreements. There's going to be a member of either the EIAC or NEDARC that will contact that designee to begin the agreement process. And so we will be sending that individual a copy of the data use agreement, the data dictionary, and then there will also be accompanied by a frequently asked questions and fact sheet. We realize that some of your hospital administrators may not be aware of this initiative, so we'll have some talking points there with FAQs. The next piece is your site visit 1 survey. So earlier this year, we asked that everyone complete the site visit survey, and it's really to develop a foundation to better understand the human and material resources that are available at your site within your pediatric emergency department or your ED facility. This visit is not intended to serve as any formal evaluation or verification process. And so for the site visit, what we were asking was that you meet the individuals who would be participating in the PRQC activities, identify some of their key strengths and weaknesses of the emergency care that's being provided, identify gaps in pediatric readiness and potential strategies for improvement. Along with the trainer, you would develop a shared understanding of the ED's landscape and then facilitate a process for team tracking and the development of team profiles. With that being said, we were hoping that all sites, and we're requesting that all sites complete that site visit 1 survey. Your trainers will be receiving a profile or a completion report this week that outlines which of the affiliate sites have not completed that information, and so they'll definitely be reaching out to you to ensure that completion. The other portion is the PEDS Ready assessment. So we definitely want to give a special kudos to our sites. I think we are it's less than about 10 to 15 sites that have actually not completed the PEDS Ready assessment, which means a lot of you all really made the most of your time with your trainers, and you did it at your site visits, or you were special students and you started a couple months in advance. And remember that PEDS Ready assessment is something that we're asking all sites to complete, and it's really going to give you your pediatric readiness score for your emergency department and an analysis of areas for potential improvement along with helpful resources. The assessment can be found at the link that's listed here, and it will also be included in your recap email. You'll want to plan about 30 minutes to an hour to complete the assessment, and so keep that in mind. So lastly, our contact information. We will have a website available for you all. You'll have a link for it in your newsletter or your recap email. And there you'll find some additional information about who's participating in the collaborative. The intervention bundles will be listed there. We'll have your monthly updates or your newsletters posted. And there will be a special section for the PRQC members that will not be available to the general public. And so more details to follow for our website. And then contact information. So your first line of defense or your first method of contact should be your trainer. They know sort of what the expectations are for the next year and a half. So start with your trainer. Then you also have your second line of defense, which is your PRQC admin team. And you can reach out to us at QECA@texaschildrens.org. And then our website. The easiest way to find it is if you Google EMSC PRQC, and you will find us. We're the first search result. So with that being said, we have reached the end of our learning session. You guys were pretty quiet for this first learning session, and we didn't have very many questions. One of those that did come in was, would today's session be recorded and available for future viewing? Yes, it will. We'll send you a recap email as well as a copy of the slides and the recording. I want to give a special kudos to the WellStar Pediatric team. All of the members of their team are in one conference room listening to today's call. So good job, the Pediatric Peaches in Georgia. Any other questions that you'd like to pose to our team while we still have about 15 minutes left on the call? Speak now, or you have a chance at the office hours that will be coming up in the next couple weeks.
And we will stay on the line for another 10 minutes or so. So if you do have questions, please feel free to put them into the chat box, and we'll try to address them.
So Kate, we have one question for Julie Gorman. I'm sorry, Julie, I don't recognize exactly where you're from at this time. It came through the question portal, and the question is, what support can the coalition provide for senior leadership?
So one of the tools that we will be providing you are some talking points. So you heard Crystal talk a little bit about an implementation guide at one point. And an implementation guide is really intended for the local grassroots effort. This is different from the implementation bundles. So separate from that, the implementation guide is really talking about how to garner support locally, how to identify processes, who to talk to, how to talk to them, et cetera, et cetera. And one of those pieces will be talking points. And those talking points will be geared to different individuals, different types of individuals, whether they be hospital administrators, ED leadership, or other providers on the front lines, and or talking points as they relate to trauma centers. If your site happens to be a level 3 or 4 trauma center, what's happening in the world of trauma networks relative to pediatric readiness and how those relate, or critical access hospitals. What are some specific talking points for you, or even community hospitals. So you will be receiving that with the implementation guide. And hopefully that answers your question. If you have more, please feel free to chime in.
Okay, Kate, I haven't received any additional questions at this time. Oh, I'm sorry. So we have a couple sites that are requesting contact information for their trainer. So what I'll do is reach out to you specifically, Cindy, with the Oregon team to ensure that you get the contact information for your trainer. Anyone else? The implementation guide. So the implementation, we just received a question stating when can we expect the implementation guide to be emailed. I'm going to pull that slide up for you so that you can see when the release dates are. Give me 1 second. So here we go. For disaster planning, the release date for that bundle will be on June 15th. Abnormal vitals will be on June 22nd. Interfacility transfers is July 6th, and weight in kilos is July 13th.
I think they might have meant the actual implementation guide as opposed to the implementation bundles.
And we're including that with the bundles.
Thanks, Crystal.
Mm-hmm. And I see that we have a couple of other sites that are requesting their trainer information. And so what we'll do is follow up with you all following today's call to ensure that you have the contact information. And that's a Texas team that's reaching out to us with Medical City.
Great. We are so excited to welcome all of you and really appreciate your time on today's call. Hopefully this was helpful, and we do absolutely encourage you to join us during the office hours and or email us if you have any specific questions or needs that we can assist with. But thanks so much for your time, and we're looking forward to getting to know all of you.